Good afternoon. We're on the compressed time zone. I want to thank those who've come to listen and to my colleagues, Drs. Geyer, Giovannitti, and Dr. Krishnan, for willingness to help in the education process. Let's see if this advances. Great. All right. The whole purpose of this event is to help the attendees to understand anesthesia education of the dental profession, specifically oral and maxillofacial surgeons. A little bit of background. Dr. Geyer is professor of anesthesiology at the University of Miami School of Medicine, chief anesthesiologist at the Bascom Palmer Eye Institute, and ASA liaison to AMOS. Dr. Giovannitti is emeritus professor and emeritus chair of dental anesthesiology at the University of Pittsburgh School of Dental Medicine and member of CODA for dental anesthesiology. And Dr. Krishnan is chair of oral maxillofacial surgery and professor of surgery at the University of Cincinnati School of Medicine, and myself, who's professor emeritus, Department of Anesthesiology and Perioperative Medicine at the University of Pittsburgh School of Medicine, ASA liaison to the American Dental Association. No panelist has any financial disclosures unless you consider being a Social Security recipient. So only our topics of discussion: how does the ADA structure education of anesthesia rotations or experiences? How are oral and maxillofacial surgeons educated with respect to anesthesia? How are dentist anesthesiologists formally educated? And how do physician anesthesiologists educate oral and maxillofacial surgery residents during their 5-month rotation in the hospital setting? There's some differences in the education process. The AAMC is independent and is not a subsidiary of the AMA, where the dental schools answer to CODA, who formally evaluate, CODA meaning Committee on Dental Accreditation, who formally evaluates dental school education and issues accreditation. They also are involved in postgraduate dental specialty education and issue accreditations. CODA answers to the ADA directly, and I'll leave it at a but, because they are times quite autonomous. The committees that are responsible for overseeing anesthesia education, the CODA, Committee on Dental Accreditation, is the sole agency recognized by the U.S. Department of Education for accrediting dental and dental-related education programs at the post-secondary level. As I said before, it's semi-autonomous. They develop and implement accreditation standards, accreditation of programs, policies and procedures, accountability and representation, and continuous improvement. Of the education bodies, CODA is really the most powerful and influential. And what does CODA really do? As I mentioned before, they promulgate standards, and they review and inspect appropriateness of education, dental students and specialty programs, because this is an important process. There's another process called the Committee on Dental Education and Licensure, and they play a vital role. I apologize. Let's see if we can go back here. They have many responsibilities, but they are in charge of what happens in the postgraduate, post-licensure period. For instance, in states where individuals would like to dentists would like to perform sedation, they are the ones that make the rules. The importance of CDEL is they created and implemented mandatory education curricula and manuals of the pre-doctoral, aka dental student, in anxiety and pain control. The ADA uses the term pre-doctoral student to really mean dental student. They created and implemented mandatory education of postgraduates practicing as with standards for provision of sedation and anesthesia using a specified curriculum and patient care mandates, and each are evaluated and, if needed, revise the standards. The 2025 revisions have just occurred or about to be published. Finally, these are available to anybody online. And here's just two of them. To the left is accreditation standards for advanced dental education programs in oral and maxillofacial surgery, and the same thing for dental anesthesiology. What is occurring at the dental school level is this particular thing, and that is guidelines for teaching pain control and sedation for dentists and dental students. And finally, who regulates the administration of anesthesia by dentists? Moderate sedation versus deep sedation, plus minus general anesthesia. The state dental boards are the ones who actually are the ultimate arbiters of who can and who cannot. But they do reflect and frequently will use the American Dental Association standards that are promulgated by CDEL. 60 hours of didactic plus 20 hours of clinical. That clinical may be hands-on plus close observation. And I'll leave that for you to digest as to what that really means. I'm going now pass the baton to my next colleague, Dr. Deepak Krishnan. Thank you.
Thank you very much, Dr. Herlick. Thank you for this opportunity to represent oral and maxillofacial surgery with this esteemed audience. My name is Deepak Krishnan. I'm an oral maxillofacial surgeon. I practice and teach oral maxillofacial surgery at the University of Cincinnati. And what I want to kind of incorporate and take on what Dr. Herlick just suggested is how the teaching of anesthesia and the practice of anesthesia in an oral maxillofacial surgery office kind of evolved along the way, and where it is today, and how we try to stay on top of things. So if you remember this picture of the first administration of ether at the Ether Dome, the person administering anesthesia is William Morton, a dentist. And why did that fall into his hands? Because as dentists, we are always faced with the perplexity and the difficulty of a patient that comes to our office complaining of a severe pain and suffering, that we are now expected to induce more suffering and then make them better from their illness. So this has always been in our court, and if you haven't experienced dental pain, it is worse than all physical and mental pain. They say if it's not physical or mental, it's bound to be dental. It's kind of a separate entity in itself. And so that becomes a huge issue. So every day we get phone calls from patients seeking our care to take care of them in a manner that is safe, in a manner that alleviates their suffering and take care of the illness further. So that has subsequently kind of morphed into the modern day oral maxillofacial surgery practice. And amongst the dental colleagues, oral maxillofacial surgeons are the ones that induce most of the injury from our surgical techniques. So we have to be on top of this game. We have to be aware of all the new things in local anesthesia and anxiolysis and behavioral management and anesthesia in the office that can keep us in our lane, that can take care of our patients in the best possible manner. And how do we go about doing that? And what is our training that keeps us unique in this lane, and what allows us to do that? Let me give you a little bit of an idea of how you become an oral maxillofacial surgeon. As Dr. Herlick mentioned, our accreditation body is not ACGME. It's not any other medical board, but it is a Commission on Dental Accreditation. And we are the only accredited surgical residency. But we often occur in an ACGME environment. In Cincinnati, for instance, I don't even have a dental college. I don't have anything that is similar to anything dentistry related. I'm a division in the Department of Surgery. And I exist as one of the few CODA accredited units in an ACGME world. So we have to abide by two masters, if you would. Everything that we do in a hospital has to be an ACGME approved thing, and everything that we are accredited to is an ADA CODA standard. All of us go into oral maxillofacial surgery training following dental school. There are some medical colleagues that come over, but they also require to go to dental school afterwards. But almost 50% of us have a training pathway that requires us to get medical degrees as well. So it typically takes about somewhere between 4 and 8 years of training in addition to dental school to become an oral maxillofacial surgeon. That could be before you become an oral maxillofacial surgeon, as in a non-traditional, non-categorical internship in surgery that kind of primes you to get into a residency, because residency is extremely competitive. And then there is a year or two after residency in specialized head and neck trauma and head and neck tumor removal, or jaw corrections and deformity correction, craniofacial surgery. So there are fellowships after the core amount of training. But all residencies require a minimum of 48 months of training in oral and maxillofacial surgery, regardless of what pathway anyone pursues. And that 48 months along the way has come to become weeks. So it's about 210 weeks of training or so. And like I said, there are people that pursue fellowships after that. In that 48 months, we have to now get anesthesia. We are the only surgical specialty that goes through formal 6 months or so of anesthesia training in the hospital system, which makes us really unique. Talk about being an amphibian. We are kind of like a bat. We are neither a dentist nor a medical physician. We fly to these mammals, and they're like, "You flew here. You must be a bird." And we go lay an egg, and they're like, "Oh, no. We are birds, we lay eggs, you have babies." So we're kind of a bat. We live in this world that bridges medicine and dentistry. And what do we do for anesthesia training? We spend about 6 months as an anesthesia resident. 1 month of it is usually pre-anesthesia in like a Center for Perioperative Care, a preoperative assessment clinic, or a medicine rotation with an anesthesiology team that looks at who is adept and who is ideal for anesthesia and what kind of stratification they require. Then there's 4 months or so on adult anesthesia. In my residency, we spent 2 months on pediatric anesthesia. Depending on which program you go to, you should have at least 1 month of pediatric anesthesia. Now, if you are rotating as a PG1 or a CA1 or a CA2, your duties as an anesthesia resident should commensurate with that of the anesthesia residents, including on-call duties for that year. So if your first-year anesthesia residents do not, in your institution, take call on anesthesia, the oral maxillofacial surgeons as a PG1 taking that rotation do not take call. But if they're doing it as a second year, and your second-year residents are required to take call, then the oral maxillofacial surgeon also has to take call with them. The code of standard specific for anesthesiology is standard 4.3.1, and that breaks down things into weeks. So we are required to have a combined assignment for a minimum of 32 weeks. In my instance, we do 36 weeks. A minimum of 20 weeks of those have to be on anesthesia service and cannot be haphazard. It has to be consecutive. It has to start in anesthesia and end in anesthesia. 4 of those 20 weeks minimum should be dedicated to pediatric anesthesia rotations. And again, like we talked about, the resident must function as an anesthesia resident with a commensurate level of responsibility. When they are off service, they cannot come back on service on oral maxillofacial surgery and attend to the oral surgery clinic or take call for oral surgery or anything like that. In addition to all of these clinical requirements, they're also required to supplement after their anesthesia rotation with a longitudinal and progressive experience throughout their training program thereafter in all aspects of pain and anxiety control. And that includes administration of GA and deep sedation for oral maxillofacial surgery procedures, particularly for pediatric, adult, and geriatric populations, including demonstration of competency in airway management, which we have specific guidelines for. In addition to all of that, we have numbers, because how do you create this issue of entrustment, and how do you make sure the competency occurs? So we have a minimum number of at least 300 cases that a graduating resident should have done with general anesthesia and deep sedation. And an experience then must involve, it's a must statement, at least 50 patients younger than 13. A minimum of those 150 of those 300 cases should be in ambulatory anesthetics outside of the operating room. So only 150 of those cases in the OR can be counted, and they should have a minimum of 300. So I thought I'll share my own experience. So I take 3 residents a year. And this is what the graduating class in June of 2025 did. So outside of the OR, each graduate did about 500 through 1,000 sedations. In addition to that, when you add up the third column there, that's what they do with the experience in the operating room and outside the operating room. Each of them do about 1,000 of those, in addition to the pediatric numbers that you see there. The anesthesia residency, the training for the resident should always be to a level of competency for delivery of general anesthesia for patients for at least age of 8, as well as, and that should include not just techniques in providing anesthesia, but also behavioral management and different techniques like inhalational anesthesia, sedations, and general anesthesia. Additionally, there's also a standard specific for anesthetic management of geriatric patients, which I'm not going to define at this point. The anesthesia training also should have a core comprehensive didactic program, and that didactic program is not during the anesthesia rotation. It should be in addition to that. That it should include emphasizing seminars and lectures on perioperative evaluation, risk assessment, anesthesia techniques, monitoring and diagnosis and management of complications. And that's very important for us to pursue. All of our residents upon graduation should have ACLS, ATLS, and PALS prior to the completion of training. And as you know very well, majority of the institutions require the RQI style now that requires them to re-up their ACLS and PALS every 3 months. Or if you're doing it the AHA style, everybody has to do it every 2 years. That's just residency, but we have a tradition and a culture of lifelong learning with oral maxillofacial surgeons that goes beyond residency. And these are often not mandated by the residency program, but mandated to require to keep your license to practice general anesthesia by your state dental board. One of those things have been in existence for almost 50 years, which is our peer anesthesia evaluation program, what we call the Office Anesthesia Evaluation Program. Majority of the states in this union require that every oral maxillofacial surgeon's office be inspected by another oral maxillofacial surgeon without conflict or bias every 5 years to make sure they adhere to every standard that is required by that state. And that's not voluntary, that's a mandate. If they do not pass that inspection, a report to the state dental board will go from there towards AMIS, and they might lose their license or their membership in the organization if they do not pass the office anesthesia evaluation. And why is that important, you might ask? Because we have an organization that 90% of our practicing oral maxillofacial surgeons subscribe to and are a part of. And a large majority of us are insured by a large national insurance corporation specific for oral maxillofacial surgeons that is tied to their membership. So if they lose their membership in AMIS, they lose their malpractice insurance. So it's important, the stakes are really high for us to continue this voluntary but almost mandated peer review process, and that's required across the land. In addition to that, every state dental board, as Dr. Herlich suggested earlier, majority of the general anesthesia permits that an oral maxillofacial surgeon carries comes from a state dental board. And the state dental boards have really tightened the regulations on the requirement for CE credits every 2 years or so. And the numbers keep going up every time I look. And that's anesthesia-specific CE credits, which is why you see many dental colleagues, oral maxillofacial surgeons, attending the meetings, including yours here this week. We have a unique program which is nationwide, currently mandated for all of our members to take every 5 years, which is a high-fidelity mastery-based practice on a mannequin called Office-Based Emergency Airway Management. And it's a very skills-based program that every oral maxillofacial surgeon in the land is currently required to take in order to keep up with their membership. And we have a good success with this program, and we are continuing to improve on what we have started about 5 years ago, and we intend to keep it going. In addition to all of this, there is an accreditation program and a certification exam for our team, the people that are assisting us. So we live in this land where we don't necessarily have a training pathway for our team, but we have accreditation and certification processes for those who are on our team, and that the DAN certified team members are required to go through a rigorous learning process and work with their surgeon in order to become certified, and that requires recertification periodically as well. The next step in the simulation program that we are creating is a cooperative adult learning program in crisis resource management called Office-Based Crisis Management, which kind of has morphed into quarterly mock drills and bi-monthly mock drills that we do for emergencies in our offices, which are now becoming state mandates in states such as in Ohio, where I practice. In addition to this, we are looking into the future to create something that engages individuals and teams using virtual reality, creating something that appears to be a game, but is actually a very reinforcing tool that helps us capture the audience, the attention span of the goldfish that we all have these days. So in order to put it on a screen and use people to kind of utilize that moving forward. So that's in its infancy as well. So those are the things that we are doing in residencies and beyonds to kind of bring our expertise and our training together to maintain a culture of safety. And with that, I will call Dr. Geyer.
Bit of a tight squeeze here. I'm glad I dieted for this panel. Good afternoon. Thank you for coming. So I'm Steve Geyer. I'm from the University of Miami. Okay. So I'm from the U, and currently the Miami, the Canes are now #2 in the rankings for college football, and the championship game is being played in Miami, and I've already bought 2 very expensive tickets to attend that game with the hopes that my team is there. If not, if anyone wants to buy some expensive tickets, I have them readily for sale. They cost more than my first brand new car cost. That's incredible. So the football team does have a university attached to it called the University of Miami, and it's a rather small or medium-sized college or university system, and attached to that is a gigantic health system that dwarfs the university itself. The U Health system sees over 3 million individual patient visits per year across more than 40 sites throughout South Florida. We actually have a few sites outside of the state of Florida as well. We have a number of hospitals, but our 3 largest ones are the main hospital, the University of Miami Hospital and Clinics. We have Sylvester Comprehensive Cancer Center, which is the only national care institute that has been designated by the government in South Florida. And we have Bascom Palmer Eye Institute, where I work. I'm the medical director of Bascom Palmer Eye Institute. We have a hospital on the health campus, and then we have a series of ambulatory clinics. So the university was established in 1952, the medical school in 1952, and it started with an affiliation with the large indigent care hospital in downtown Miami, Jackson Memorial Hospital. They agreed to integrate their services, clinical services, teaching, research, etc. In 1973, the Public Health Trust was established to help those without any alternative means for health care. And the Public Health Trust encompasses Jackson Memorial Hospital and all its branches. Jackson is a very large tertiary care center hospital. It is the safety net hospital, is the teaching hospital for Miami-Dade County. The system also includes Ryder Trauma Center, which is the largest trauma center in the Southeast, Holtz Children's Hospital. There's 6 other major hospitals as well. The Public Health Trust hospital system is the 3rd largest employer in Miami-Dade County. It is massive. Our oral surgery residents train mostly within that system. Most of their training occurs in the main hospital, Jackson Memorial Hospital, but they have clinics in the other Jackson hospitals, right? In and adjacent to, because some of them are actually considered office-based clinics. There's also our residents, oral surgery residents, get training at Bascom Palmer Eye Institute. It's an eye hospital, so we have an abundance of healthy pediatric patients and syndromic pediatric patients. It's a very nice mix. And as I'll tell you in a few minutes, there are other locations that they can get some pediatric training as well. And the goals, of course, of the anesthesia experience is to teach general anesthesia, to teach sedation techniques for surgical procedures amenable to the subspecialty, right? And to do it across an age range, pediatrics, adults, and the geriatric population, with an obvious emphasis on oral and maxillofacial procedures. I love giving this talk because I get to show you pictures of my friends and talk about my program. This is Dr. Rafael Rico, who was a resident of Dr. Andy Herlick many years ago and remembers him very fondly. He's in charge of the 4-month anesthesia rotation that Deepak described so deftly just a few minutes ago. That occurs exclusively at Jackson Memorial Hospital. The faculty are all anesthesiologists, and it's mostly adult and general and geriatric patients. It's an inpatient hospital with HOPDs as well, or hospital-affiliated ambulatory surgical procedures. So in the first 2 months, the oral surgeons are paired with an attending and an extender, typically a nurse anesthetist. And that's just make sure that we can keep everything safely for people who are just beginning their residency and have no other exposure. The anesthesiologist is on a 1 to 2 supervision ratio. And in the beginning, we start off with monitored anesthesia care cases, hand, podiatry, GYN, urology, et cetera. And they try to get ASA 1 and 2 patients, which you can imagine may be difficult in such a setting. Around the 5-6 week mark, they're weaned to work exclusively with an anesthesia attending. And that's where the focus is more on general anesthesia cases, GYN, urology, colonoscopies, things of that sort. But there's also a preferential assignment to oral surgery cases. In the PGY3 year, and we've split it up and we've gotten permission to do this splitting up, we feel that pediatric anesthesia is more beneficial when a resident has had more years behind them and are more matured. So for us, we have an exception. We're allowed to do it in the PGY3 year. They do a 1-month rotation at Bascom Palmer Eye Institute. Again, our faculty there are board-certified pediatric anesthesiologists that are supervising the residents. And again, it's a 1 to 2 maximum ratio. Sometimes it's 1 to 1. We'll put a pediatric anesthesia attending in the room solo with the oral surgery resident. Most of our patients, again, are outpatients, and again, composed of both healthy and syndromic patients. In the 4th year, there's an option to augment the pediatric anesthesia experience. So it's more up to the resident's preference. It's not mandatory, but the majority of them actually do avail themselves of it. At Jackson Memorial, they have a pediatric special procedures unit, and that one is staffed by 2 anesthesiologists. They are pediatric cardiac anesthesiologists. You really don't get any more intensive in the world of anesthesia than those 2 people. And often the assignments are a 1 to 1 ratio, or occasionally it's on a 1 to 2 ratio. And the patients there, it's a pediatric special procedures unit, but as you can imagine, because a lot of the children are affected and such, people can be up into their 20s and 30s there as well. This is my good friend Yao Sawatari. He's a professor of oral surgery at the University of Miami, and he's the director of the OMFS residency program. He deals with the residents in their PGY 2 to 4 years in their clinics, in their outpatient clinics. They're all CODA certified clinics, and also they're scattered throughout Dade County. Most of them are Jackson Memorial clinics or offices, but there is one University of Miami-based one as well. And this is exclusively OMFS procedures. So I first met Yao when he came to Bascom Palmer to transplant an eye tooth into somebody's eyeball. And I thought that was an unusual idea when it was first proposed. But we've done a number of these where they take the eye tooth out and they implant a lens in it, and then they implant it into the cornea of someone who has either Stevens-Johnson disease, some corneal disease, a blind person, and with an intact retina. And so at the end of a series of surgical procedures, you take a blind person and now they can see. And so it's an interesting link between oral surgery and ophthalmology and anesthesiology. And every time I met him for like the first 2 years we started doing this, I would always ask him, who thinks of this, right? Who thinks, oh, there's an eye tooth. Let me put it in someone's eye. I don't know. But he's really a wonderful guy. He's very diligent. He monitors that all of his crew are doing what they need to do across all age ranges and case types. They have 16 OMFS residents, so that's 4 per year. And Deepak showed his numbers. I don't think mine are quite as plentiful as his, but again, they satisfy all of the requirements every year in terms of the number of minimum cases, number of pediatric patients, number of deep sedation cases, and the number of cases they do specifically with oral surgery patients. What do we teach them? Of course, we teach them the basics of airway evaluation. We need to have a common knowledge, right? When we're in the OR together, we need to understand each other's needs and each other's concerns, right? And so I think it's important that we learn the same language. So we do a lot of emphasis on that, and obviously how to capture an airway is a big component of what we teach. I've had the pleasure of participating in the AMOS office-based emergency airway management course. And one of the things that I picked up was that they have an emphasis in the office. If you need to rescue someone, if you're in a situation where you have to intubate them, they're advocating the use of handheld disposable video laryngoscopes. And it makes sense because they're cheap to acquire, right? They're a lot less money than a CMAC or a glide scope or any of the equipment that we routinely use in our operating room. They're readily storable and they're readily accessible. So what we've done is we're starting to mimic that as well in our program. We have purchased a number of the same brand of disposable video laryngoscopes so that our oral surgery residents can get exposure to using that type of equipment. But at Bascom Palmer, what I'm doing now is we've broken out the McGrath equipment, which is the non-disposable handheld video equipment as well. Of course, we teach supraglottic airway techniques. One of the things that we do at Bascom Palmer is we do an abundance of oculoplastics procedures in which there's biopsying of oral mucosa by the surgeons. And so we try to put the oral surgeons in there, oral surgery residents in that room, or at least bring them in to get exposure to the use of a flexible laryngeal mask airway, which is really a nice device. You can actually twist it in a knot and it'll still ventilate, although I wouldn't recommend that doing on an actual patient. But it's really good. You can put the shank in whatever quadrant you need and manipulate it around and work around it. And I think it's a beneficial part of learning and part of the experience. Another thing that we're using now is we're using video supraglottic airways. We've been using them for about 2 years. And I'm still working out the utility of using this for the oral surgery residents. I think it might have a good application in terms of rescue. But it's nice. You can actually see where you're going. You can see the airway as you approach it. You have a nice lever there. You can see that the vocal cords are open and the patient is nicely anesthetized. You can take a photograph. You can watch as the cuff goes up so that you just put the right amount of air in it. You can reconfirm that the cords are open so that you know on that first breath the patient is nice and deep, right? And so you don't have to go through the differential of why I can't ventilate this patient. Are they too deep or is it in the wrong position? I think there's going to be some utility there, but it's evolving. I would be remiss if I did not talk about Charlie Cates. Charlie Cates had a 50-year career at the University of Miami. He was the founder of the Division of Oral Maxillofacial Surgery's anesthesia program. He was the director of anesthesia there from 1971 to 2021. I had the real honor of penning a chapter for a textbook of anesthesia for oral maxillofacial surgery about 8 or 9 years ago with him, recognition and management of the difficult airway. And he was really quite a teacher for both anesthesiologists and for oral surgeons. He had about a half dozen ways of doing a blind nasal intubation. And he had an incredible means of wrapping the head such that it was totally secure, that there would never be any accidental dislodgements of the endotracheal tube intraoperatively, while you're doing field avoidance and you're away from everything. Very low profile. It was more artwork than science, but he was really quite a guy. One of the things that I used to do with him that I really enjoyed doing, I'm not sure if it's done much anymore, submental tracheal intubations in which the endotracheal tube would be tunneled underneath the chin so that it would allow access to the facial bones during surgery and also allow for dental occlusion during the surgical procedure. But it was quite interesting being with him. Quite a guy. And that's my talk. Thank you.
Our last speaker is Dr. Joe Giovannitti, emeritus professor from the University of Pittsburgh. He's going to describe the training of dentist anesthesiologists. And Joe's been quite a colleague and friend of teachers for many, many years. And he spent a significant part of his career practicing in this state. Welcome back home.
That's not it. Okay. How do I do that? Okay. Great. Okay. Great. Thank you. There it is. Okay. Thank you. Thanks, Andy, for that introduction. My name is Joe Giovannitti. I'm a dentist anesthesiologist, now retired, which is wonderful. I highly recommend that. I have been in practice for about 47 years before I retired. And just a little bit of background. I graduated from the University of Pittsburgh Dental School in 1977. I completed a 2-year anesthesia residency at the same institution, UPMC now, in 1979. And I practiced for about 22 years here in the state of Texas in the Dallas area, providing anesthesia services for dental offices in the community. Also taught at the Baylor College of Dentistry. And then I came back to Pittsburgh, and I was on the faculty at the university there for another 20-some years. Was chair of the department for a while. I'm currently a commissioner of CODA that you've heard about, and past president of a couple of our national societies and our dental board. These are the current residency programs now for dental anesthesiology. There's 10 programs nationwide and one in Canada as well. And you can see for yourselves where these training programs are. We are always hopeful to increase the number of training programs as the years pass. Since CODA accreditation has come, we've increased our programs significantly. The American Dental Board of Anesthesiology is our board certification organization. It was founded in 1994, and it establishes all the criteria for diplomate status. And it's a 2-part examination. It's a written exam, and then a year later there's an oral exam. And the majority of our dentist anesthesiologist graduates take this exam, and the majority of them are board certified at this point. As far as the evolution of training for dentist anesthesiologists, it all started out way back in 1844. But we had a lot of training by apprenticeships in the early days. For example, the founder of our program at Pittsburgh was a guy named dentist by the name of Leonard Monheim. And he learned anesthesia as an apprentice to a physician anesthesiologist in Pittsburgh. And he trained for 3 years with this person and was hired by the UPMC system and became the only anesthesiologist at that UPMC for 20 years. And he was actually responsible for recruiting a lot of the physician anesthesiologists to our university. But he learned it as a physician. He started in 1949 with our department in our dental school. and started training dentists. And the advent of a one-year program came about, and these were nationwide. And most of the people who went through a one-year training program in anesthesia did it as a precursor to their oral maxillofacial surgery training. And they really didn't go into an anesthesia practice. Somewhere in the mid-1970s, there was an outcry from dentists that wanted to pursue anesthesiology as a full-time career option. So in the mid-70s, two-year programs were developed. And this is the program that I went through. And this was designed specifically for people who wanted to practice dental anesthesiology in their communities. This went on to about 2015. And in 2015, because of advances in medicine and improvement in technology and equipment and increasing patient medical complexities, there was a need to increase the training duration. In 2015, it went up to a 36-month training program, and that's what's currently available right now. And in 2019, dental anesthesiology was officially recognized as a distinct specialty of dentistry. Before that, we were considered to be general dentists who practiced anesthesia, but now, since 2019, it's a fully recognized specialty. And we talked a lot about what CODA does. CODA started accrediting dental anesthesia programs in 2007, and all the programs are currently accredited by CODA. And because of this accreditation, they're eligible for ACGME funding, and this is how our residents are paid. And they receive a stipend, and also some of those funds flow back to the sponsoring hospitals and to the dental schools, so they can generate some income for the departments. There's currently no cap for dental residents, and so there's an unlimited number of dental opportunities. So if any of you have a program that needs to increase your income, hire some start a dental anesthesia program and bring some income into your department. But these programs then, because of this funding, are self-sustaining. CODA has specific standards for the training of dental anesthesiologists. There's 6 standards that are very rigorous and must be followed to the letter in order to get their accreditation. I do a lot of site visits as a CODA commissioner, and we look at every one of these standards in detail to see if they're being met. And if they're not, then there's an issue that needs to be resolved. The first one has to do with the institution and the program effectiveness. All the programs have to be sponsored or co-sponsored by a U.S.-based hospital or educational institution or a healthcare organization that's affiliated with an accredited hospital. And it also has to be accredited by, or could be accredited by, an agency of the Centers for Medicare and Medicaid Services. So that's the requirement for the program to exist. The second standard is a big standard about the educational program itself, and it talks about the curricular content and the training requirements. And there's competency requirements that have to be listed and met by each resident. And, the training has to be comprehensive, and it has to be a 36-month duration, and it has to consist of outpatient dental procedures as well as hospital-based types of cases. And these cases aren't limited to dentistry. The residents are trained in every aspect of medical anesthesia. These are the minimal clinical experiences that are required by dental anesthesiology. It's 800 total cases of deep sedation and general anesthesia, 300 cases of intubated general anesthetics, 50 of those have to be nasal intubations, and 25 advanced airway management techniques. 125 children under the age of 7, and 75 patients with special needs. And these have to be sufficient to meet the competency requirements that CODA sets up. And we have to manage ambulatory patients and geriatric patients, ASA 3 and greater patients, and patients requiring moderate sedation. So just about everybody gets managed by these residents. In addition to the anesthesia training that they receive in the hospital, they have to go on certain medicine rotations. And the programs can choose 4 of these from these lists, but they do 4 months of off-service, if you will, training. And you could either do cardiology, emergency medicine, and you can see the list there. And they do 1 month each in these rotations as well. The third standard has to do with the faculty and staff. The program director has to be at least a 40% appointment in the sponsoring or the co-sponsoring organization, and has overall responsibility for the program. And then the staff has to be, your faculty has to be qualified by their education and experiences in order to be on the faculty in order to comply with this standard. Standard 4 has to do with the educational support services. So there has to be an adequate learning resources like library and access to texts and things like that. And then there has to be specific written and admission criteria and policies and procedures manual. There's has to be a due process, and there's health services need to be available for the residents. Standard 5 has to do with facilities and resources, and they have to be adequate to provide the didactic and clinical experiences and opportunities required to fill the needs of the program. And then the 6th standard is a research, and the residents are required to engage in 1 month of scholarly activity and present their results in a scientific or an educational forum. And that's usually the result of a publication or a presentation at a national meeting or some other things as well. We have a journal called Anesthesia Progress, which is the journal that a lot of our people publish in. It's a dental anesthesiology journal, and it has a lot of good research and material in that journal. I'm from the University of Pittsburgh, so I'll talk about our program briefly. It's a unit of the UPMC system, and we take 4 residents per year, so we have a total of 12 residents. And the training experiences are coordinated by the program director, who's based in the dental school. He's a dentist anesthesiologist, but he does it in conjunction with the medical director at the UPMC. And it's a 3-year program. About a year of it is spent within the dental school. We have a full capability in our dental school. We've got 12 anesthesia machines throughout the school, different operating theaters where we can do oral surgery and pediatrics and a variety of other things. So the students get a lot of their ambulatory dental training there at the school. We teach them practice management. We give them a lot of didactic instruction. We have a formal curriculum for them, simulation, and they do a huge amount of clinical application at that time. Usually each resident does probably about 150 cases, while they're at the dental school. And they get some teaching experience as well. They teach other residents things like medical emergencies, so they get some teaching experiences, how to write a lesson plan and things like that, as well as lecturing. We have a large center for patients with special needs in our dental school, and we do hundreds of cases with these types of patients, general anesthesia for their dental procedures. After they get their dental school experience, they do the UPMC hospital rotations, and these are 2 or 3 month rotations depending on which hospital they go to. Presbyterian Montefiore is the flagship of UPMC, and they train there for 3 months. They go to UPMC Mercy. McGee Women's Hospital is on the list. Now, we don't have any standard that has to do with obstetrics or gynecology, but they spend 2 months at this hospital, and they do spinals and epidurals for labor and delivery. And it's a great experience for the residents. Really have a great experience. They're well received there, and they really love that rotation. They go to Children's Hospital, and then back to the School of Dental Medicine, and then they do their off-service rotations in internal medicine, intensive care. They go to the Children's Hospital emergency room, and they do cardiology. Our program is administered through the Dental Anesthesiology Training Committee, which consists of the program director and the medical director, as well as some of our faculty. And it's involved in doing internal reviews, doing resident evaluations. There's faculty evaluations that occur. We give mock oral boards to the residents before their graduation. There's an outcomes assessment written examination, which is administered by the ADBA. It's a national exam that a progress type of exam that's given every year. Nationwide, all of the programs, residents take this exam on the same date and the same time each year. And it's a good way to assess your residents' progress with each other, with their peers around the country. There's an exit interview, there's an alumni survey that's done, and CODA comes every 7 years, and they will inspect our program to make sure that we are up to snuff with the meeting the standards. And one of the outcomes that we have is our ADBA certification. We make sure that our residents are prepared to take and pass this examination. So what does a dental anesthesiology specialist do after they get all this training? Well, they can be educators. I spent 20 years at the University of Pittsburgh on the faculty there, and we teach pre-doctoral, postdoctoral, and continuing education programs. Also, they can be practitioners, either in a dental school environment or hospital environment, or mostly in a private office setting doing ambulatory anesthesia. This helps increase access to care for dental patients, especially kids and patients with special needs, and it helps increase public awareness. People out there now, they're starting to realize that they can go to the dentist and have an anesthesiologist help them with their procedure. And then researchers, there's a lot of research being done in this field. Our journal is full of really interesting research that's being done that's pertinent to dentistry and medicine as well. As a faculty member, one of our jobs is to try to create an academic department within the dental schools exclusively for anesthesia, and then to collaborate with the hospital and either if they have a program, collaborate with to advance the program or to develop a new program. Also, we try to develop teachers and practitioners and research as well. And we provide a huge clinical service in the dental school. At Pitt, we provide anesthesia services for other departments. So we do a lot of oral maxillofacial surgery cases, periodontal cases, pediatric dentistry, endodontics, and special needs. And basically anything that can be done in dentistry, we can be involved with. And on the pre-doctoral level, we teach dental students how to give local anesthesia for all of their intraoral blocks. We teach pain and anxiety control courses. We teach them how to administer nitrous oxide and oral medications. And we teach medical emergencies and bring them to a simulation center to augment our didactics. We teach a clinical medicine course. And we teach the students how to perform medical consultations when they have medically compromised patients so that they can speak with physicians intelligently to gain the information that they need. And we teach the students BLS as well. On a postdoctoral level, we teach courses to other residents in the school, like oral surgery residents, periodontal residents, endodontic residents. We teach them a course in medical emergencies, pain and anxiety control. BLS, ACLS, and PALS is taught through our department, and we have our interdisciplinary training and teaching as well. We give lectures to other departments and our residency direction. Services to the community, we have a lot of things that we do in the community. Patients come into our special needs center, we service them. We have committee activities, and we provide services, again, like I said, to everything within the school. And then we do a lot of research and publication and public speaking. So that's what they can do in an academic environment. What do they do in a private practice environment? And this is an example from a colleague's private practice. This is an office-based practice. They go from office to office and provide anesthesia services. And you can see that the majority of cases done by this practitioner were pediatric patients, but they also do a significant amount of oral maxillofacial surgery, periodontics, endodontics, general dentistry. Just about anything has been provided here by this practitioner. And then the average case length, how long we spend there. This particular person averages about 2 hours, give or take, for most of the different types of procedures that you can see there. As far as how many dentists this person works with, they work with 161 different dentists. And they'll provide these services, and you can see, again, the majority, they work for 50 different pediatric dentists and a lot of general dentists. You can see the distribution there. So there's a lot of different things that the dentist anesthesiologist can do as a sole practitioner providing services, for other dentists. And this is the end. Thank you. Oh, that's right. I don't have to turn that off.
There's a few minutes left for any questions, comments, observations. This is a little less contentious than in previous years, where emoting was the rule rather than education. So I invite anybody, please step to the mic, make observations, comments, criticisms. Just one moment. Put on my Kevlar dress. Okay, now I'm ready.
Stefan Lucas. I'm an anesthesiologist, I guess traditional physician anesthesiologist, but I have exclusively dental practice in the office-based setting. And I have a dental anesthesiologist who just recently graduated that moved to our area. His wife's a pedodontist. I work with her, and it was interesting that I think there was a lot of concern when he moved in that I was going to be hostile. And I'm like, there is so much work in this environment. And I'm like, listen, can I just send you all the offices that I can't service that are looking for dental anesthesia services in the office-based setting? And grew his practice from not really doing anything in the course of 2 months. He's basically working almost full time. I'm interested in knowing if there's any movement in making sure that dental anesthesiologists can be reimbursed through medical insurance. I know that you guys have some preferential treatment through dental benefit plans, and I'm going to just express my complete ignorance on this right now. It's the Wild West, and I've been doing this for 12 years. Really only the last 2 years have I been predominantly doing dental anesthesia. And it's been a wild ride trying to figure out how to provide the care that is clearly needed in the community and not get screwed by the medical insurance. So I've had to do some interesting contortions where I have two different businesses, where one is my adult business and the other is my pediatric insurance reimbursement business. And even though I'm the same person showing up to both places, I kind of put on a different hat at each one. So I'm interested in helping grow the field, because it's clearly there's a huge need, and I think the 10 schools that currently exist can't produce enough providers fast enough to meet the need.
Let me give you an anecdote. When Joe retired in the end of January 31 of 23, February 1, I took over to help him. I found out that I could not bill because as a physician, I could, for Medicaid, dental Medicaid, you could not do it because it's medical. These were a lot of bills that did not get fulfilled. Now, that's in the Commonwealth of Pennsylvania, but I found out when looking in Nebraska, the same thing occurred. And I was asked, I don't know what the experience is elsewhere, but it's a challenge, to say the least. Now, I don't think I'm speaking out of turn, am I? Okay. This is a big challenge to that environment. So producing anesthesia providers, whether it be dentists, anesthesiologists, oral surgeons who preferentially want to be a provider of anesthesia services, it's okay. But if you have an MD and you don't put the DMD before the MD, oops. And I put the DMD before the MD, it still didn't matter because I only practiced, I don't have a dental license, I only had a medical license. It's a challenge, to say the least, and that's a problem. One of the things that we did at the University of Pittsburgh during my year there is we started the first rotation for CA3 anesthesia residents to teach them how to do office-based anesthesia. That's not happening in this country enough and fast enough, because it's not so easy to just suddenly jump out of that airplane of training and wind up in an office-based environment. It becomes a morph. And I think we have the director of a very large program in Chicagoland, Dr. Valish, who can maybe address those issues about physicians working in dental offices and their training. Maybe would you like to step up to the plate on that one?
Sure. Working through SAMBA and our office-based anesthesia committee, and based on Boris's experience with you at Pitt, we've been working on trying to get med student and resident rotations for physician anesthesiologists through dental offices, so they can start to learn. As you notice, the training programs of both oral and maxillofacial surgeons and dentist anesthesiologists include actually doing anesthesia in the office, which, as you know, is very different than doing anesthesia not in the office. So we're certainly working on that. We did also manage in Illinois last year, just a year ago, to get physician anesthesiologist added to the list of people who could bill for anesthesia services to Medicaid in the state of Illinois for dental cases. So
well, that is remarkable that it was able to be pulled off. Thank you for doing that.
It worked only by magic after about 12 years of doing it that an anesthesiologist was elected to the Illinois General Assembly. And during a conversation, and I had coached him very well, and during a conversation with the Director of Health and Family Services in Illinois, who was complaining about there not being enough anesthesia coverage for Medicaid cases, said, well, if you just paid anesthesiologists to do the cases, that you would have some coverage. I don't know what you're talking about. We pay them a lot. And he said, no, you only pay dentists. You won't pay physicians. And the next day there was a memo and it was fixed.
It's interesting that there was, quote, a memo, that you described a memo.
Literally is a memo. Yeah, I have it. You should run for office in all your free retirement time. We could fix all these problems.
I am a judge of elections. What else do you want me to do? And in Pennsylvania, we still do not have a budget. We're in, month 4 of this lack of budget? You can imagine how long it would take somebody to write it, especially since our governor is the nephew of a Harvard anesthesiologist who is one of the gurus of office-based anesthesia. So let's try to figure that one out. Somehow, when I said, Fred, why don't you go talk to your uncle or your nephew, somehow that conversation didn't exist. It was in one ear and out the other. So we have the challenges. We are now, and I think the next group is coming in. I wanted to thank the executive board from the American Association of Oral Maxillofacial Surgeons for coming and listening, and hopefully we did not have the contentious behaviors of previous years. Thank you for attending. Thank you for the collaboration. This was a very honor for my colleagues who came to the podium. Yours?